Would somebody indicate to me by way of chat that you can see the screen and hear me speak? I would appreciate it. Thank you very much. I appreciate it. As you can hear, my voice is pretty rough. I've been a little bit sick over the weekend, and so we'll try to do the best we can as we progress through this today. I do apologize to you for that, but there's nothing I can do other than rest and the usual stuff. I had just put up week 6 and had pressed save, or actually pressed cancel instead of save. And so I'll have to redo that because as a general, I don't save those. So let's go to our calendar of activities and see what we're doing this week rather than do week 6. Week 6 will be back up there as soon as this class is over. Having a little bit of a rough start here this morning. So we'll go to week 6. We're still on track. I will remind you that the big thing today is exam 1 is closing. Exam 1 is closing. Closes tonight, 11:55. I just checked on my app. 10 of you out of the 16 have taken the exam. That's just good. For the rest of you, my advice to you, as always, is not to wait to the last minute. If you wait to the last minute, the possibility exists that you could lose your internet. Something could happen to your computer. Something could go wrong at the school with regards to the technology or something like that. And you would miss out on the opportunity to take the exam. If that happens, we have no recourse. If you're not able to take the exam because of a technical reason, we have no recourse other than you having to take the makeup exam at the end of the semester. As you're well aware from the review last week, the exam consists of multiple choice, true, false, matching, and short answer questions, okay? We had a thorough review of the exam last week. And if you are, for whatever reason, are technically unable to complete the exam because you waited to the last minute, then you're forced to take up the makeup exam. Makeup exam will still be on the same chapters. Unfortunately, it'll be a short answer and essay, and you won't have the advantage of having the multiple choice, matching, and true false questions. So if all possible, make sure you complete the exam before 11:55 tonight. If for whatever reason you're not able to take the exam, you're sick, your kids are sick, as I've told you before, you must notify me before the deadline. You must notify me before the deadline, which is tonight at 11:55 p.m. Notify me as always by way of Outlook mail, okay, the school email. I have 3 classes now, Monday, Wednesday morning, Monday, Wednesday afternoon, Monday, Wednesday evening. So I'll just make sure in the subject matter line, you place Monday, Wednesday morning to make sure that we understand, okay, or I understand which class you're in, and it helps me to help you in a more expeditious fashion. So we're in week 6. We are starting the last chapter in the second module. Remember, our first module was the cardiovascular system, the blood, the heart, and the blood vessels, which is what you were tested on, okay? Second module, is the lymphatic system, the immune system, which you've been working on the homework, okay, which is due today. And now we had the respiratory system. It doesn't really fit in per se with any of the other systems. And so to sort of equally divide the chapters. And since it is the next chapter in the textbook, we're going to do the respiratory system. As you can imagine, the respiratory system is very, very, very important. Okay. So we have two chapters. We have, excuse me, we have one chapter. We have two lectures, a lecture today and a lecture on Wednesday. You have a lab module. Okay. The lab module consists of two portions, an interactive physiology portion, which you have done before, and a PhysioX portion, which is on Pearson. Okay. A PhysioX portion, which is on Pearson and is labeled as homework. So let's look at the module itself. We'll scroll down to chapter 22. As always, we have the students' notes. These came from Dr. Oler. I've been using them for a while. The PowerPoints. We have lecture videos from previous lectures. Okay, we have lecture videos from previous lectures. And so we have a couple of different lecture videos. If for whatever reason you would like to go back and listen to this lecture again, wouldn't be this lecture, because I don't record the live online lectures except for the purpose of attendance. But at one of the lectures in the past, which are very similar to this chapter, because this is the same lecture I gave last semester. Okay. So you have those lecture videos. As always, if you need additional resources, just go to YouTube, type in Merib chapter 22, Merib chapter 22. Merib chapter 22, that's our chapter, and a number of lectures will come in. Merib is the most common textbook for anatomy and physiology, both in AP anatomy and physiology in high school and for college anatomy and physiology, introductory anatomy and physiology. So there'll be a number of people that are lecturing on chapter 22, and sometimes you need to hear it talked by a second person. As I've always talked to you about the light bulb moment, sometimes the light bulb moment won't go off for the first 2 or 3 times that it's gone around. In our lab modules, we have an interactive physiology. As you're aware, an interactive physiology requires you to log into Pearson and to watch these short animations. Most of these animations, 4, 5, and 6 minutes, okay? And these animations are important. Number one, they're talking about gas exchange in the lungs. The lung anatomy is not complicated at all. As I told you previously, Anatomy and Physiology 2 is primarily a physiology course with some anatomy. And Anatomy and Physiology 1 is an anatomy course with some physiology. So you're going to watch these videos here, and then you're going to fill out this worksheet, okay? This worksheet is just so that you get an idea that you have an understanding. So the best way to do this is download the worksheet, watch the videos. As you watch the videos, fill out the worksheet. The worksheet's not very long at all. Okay, not very long at all. And then once you're done, you save the worksheet as indicated, last name, first name, underscore, and then however it's saved up here in the instructions, and it'll tell you how to save the instructions. And then you put it underneath assignments. It'll be respiratory lab, interactive physiology, okay? The second portion of the lab module in respiratory physiology is a more interactive thing, okay? You should say PhysioX. Second part of your assignment is under Pearson. We used to do them outside of Pearson, or actually do with Pearson, but one of the components that Pearson required to do the lab and then to upload it into assignments is no longer accessible. And so now we do the labs. This is the same lab, it's just done in Pearson, and it's submitted in Pearson. So that's one less assignment that you have to do. And it's in activity 1. It's in activity 1. And so these assignments will be due, as always, a week from Wednesday. We always have the assignments. So you'll have a Pearson assignment, which is the chapter test on chapter 22. That's a Pearson assignment. Your 2 lab assignments will be the interactive physiology and the physio X assignment, and they will be due a week from this Wednesday. So there is not a whole lot of work to be done. It is the whole purpose of this respiratory chapter is to learn the physiology of the respiratory system, because it's not that it's complicated, but that it is very detailed. It is very detailed. So we're going to start on the respiratory system, okay, and get through the slides until my voice gives out. This is the respiratory system. Remember, all the system, these are not necessarily artificial things, but remember all the systems interact. We can ventilate, we can take in as much oxygen as we want to, but unless we have a method of transporting that oxygen from the respiratory system, from the lungs to the cells, which are every individual cell in the body needs oxygen, with the exception of blood. And as you recall, blood does its cellular respiration anaerobically, because prior to becoming a functional unit, hemoglobin becoming a functional unit, it expels its nucleus and most of its organelles. So we'll look at the respiratory system. What's the function? Everybody thinks that the function is to supply oxygen to every cell in the body and remove carbon dioxide. When we do cellular respiration in every cell in the body, we combine glucose, which was produced by way of photosynthesis, unless we had to make it on our own because we didn't have enough. We had to do gluconeogenesis. We combine glucose in the presence of oxygen. We get CO2, water, and ATP, okay? And we'll study, when we get to metabolism, we'll go back through glycolysis, the Krebs cycle, and oxidative phosphorylation again. So primary things that we think about are supply oxygen to and remove carbon dioxide from the body tissues. We also filter particulate matter. We condition, so as we breathe in, especially if we breathe in through our nose, we have a number of opportunities to remove the particulate matter that we breathe in. We're breathing it in all the time, okay? All you have to do is see a sunbeam coming in and look at the dust that's in the air, okay? And we're going to condition the incoming air. We're going to warm it up and moisturize it. In addition to that, by way of our respiratory rate, we can regulate pH, and then phonation, being able to talk just the way that I'm talking right now, or hopefully you're talking better than I am. Phases of respiration. We have 3 phases of respiration. We have first the mechanical phase of just bringing in air into the lungs and having air go out of the lungs, bringing air into the lungs, movement of air into and out of the lungs. And this is purely a physical phenomenon. When we contract certain muscles, and we will go that in detail, when we contract certain muscles, we change the volume inside the interthoracic cavity. When we change the volume, when we increase the volume, the pressure decreases. So the pressure inside our chest decreases, and it decreases less than the atmospheric pressure. So we've got atmospheric pressure outside, which at sea level, which is what we are, is 760 millimeters of mercury, or 1 atmosphere. Inside, we've got something less than that. So the pressure goes downhill the gradient, and so air is going to come in. And so we're going to contract certain muscles, primarily the intercostals and the diaphragm, and that's going to increase the volume, and air is going to come in. When we get ready to expel the air, we just relax the muscles, okay? So inspiration is an active movement. Expiration is a passive movement. So we just relax the muscles. So we relax the diaphragm, relax the external intercostals. Those are those muscles along the chest. We relax those. Once we relax those, we relax the diaphragm goes back up. When the diaphragm contracts, if you remember, the diaphragm is the muscle separating the thoracic cavity from the abdominal cavity. When it contracts, it goes downward, increasing the volume. When it relaxes, it goes upwards, decreasing the volume. All of a sudden, we've done the opposite now. We have decreased the volume. We have decreased the volume inside the chest. And by decreasing the volume, we have increased the pressure because we equilibrated. We were now at 760 outside and 760 inside with our inspiration. We've now equilibrated, except now the pressure inside the chest is greater than the pressure outside the chest, and air is going to flow out by passively, unless you forcefully try to expel all the air, like you're blowing out the birthday candles or you're taking a inspiratory test. Okay. So that was our first stage, just pulmonary ventilation, just moving the air. That's all we're doing. We're moving oxygen into the lungs. Okay, that's all we're doing. Okay. External respiration. The oxygen does the cells no good. The oxygen does the cells no good unless we can transport it from the lungs to the individual cells. So we need to have a gas exchange. We need to have a gas exchange between the lungs, between the individual smallest unit of the lungs, which is 1 cell thick, which is called the alveolus. Okay, and we'll look at the pictures of that in a little bit. We need to have that gas be able to go out through that 1 cell wall thick into the interstitial space, into the interstitial fluid. Remember, we've talked about fluid compartments before. There's intercellular fluid and extracellular fluid. Intercellular fluid is the fluid inside the cell. Extracellular fluid has 2 components: interstitial fluid, which is the fluid that surrounds all the cells and the blood vessels, and intravascular fluid. So that fluid's going to go out. So in this particular case, it's actually a gas. Gas is going to go out from the alveolus into the interstitial fluid, and then is going to go into the capillaries, the capillary bed that surrounds all our cells. But this would be the pulmonary capillary bed. And so then we're going to have oxygen go out of the lungs into the interstitial fluid, and then into the capillary bed. And how is it going to do this? It's going to do this by way of simple diffusion. Okay. Remember, diffusion is the movement of a molecule or molecules down a concentration gradient until equilibrium is reached. Okay. So it's the movement. So we have obviously a higher concentration inside the lungs of oxygen. And so that goes out into the interstitial fluid, and the interstitial fluid then has a higher concentration of oxygen, which then goes into the capillary bed. So now we've got the oxygen in the capillary beds. So that's our external respiration. So we had mechanical ventilation, we have external respiration, and the oxygen is moving. The oxygen is moving by way of simple diffusion. The CO2 does the same thing, but in reverse. The CO2 is brought into the lungs, okay? The CO2 is brought into the lungs by way of the capillary bed. It's in a higher concentration in the capillaries, so it moves to the interstitial fluid. And then from the interstitial fluid, it moves into the lungs and is able to be blown off, okay? And then finally, we have internal respiration, which is gas exchange between the systemic blood cells, okay? Between the systemic blood and the cells. In other words, between when we get down to the individual cells, we have another capillary bed. Remember, it requires capillary beds for the exchange to occur. We don't have exchange occurring in the cells around the aorta. The aorta is too thick. The major arteries are too thick. The arterioles are too thick. Exchange occurs at the level of the capillary. The capillary is 1 cell wall thick with a basement membrane, where whatever we're doing, okay, if we're talking about the alveolus, it's 1 cell wall thick with the basement membrane. So we transport the respiratory gases. So we have a particular mechanism for transporting oxygen and a particular mechanism for transporting CO2. Oxygen is primarily transported as with hemoglobin in the red blood cell. It's not the only way it's transported, but it's the major carrier, okay, of oxygen. CO2, some portions of CO2 are transported in hemoglobin, but the major portion of CO2 is transported as the bicarbonate anion, okay? Remember, an anion is an element or group of elements that have gained or lost electrons. And so in particular case of an anion, it has gained electrons, okay, and has become, because it gained electrons, a negative charge. Functional anatomy of the respiratory system. We have two big areas of the respiratory system. We have the conducting zone from the nose to the terminal bronchioles, okay? From the nose to the terminal bronchioles. So FSCJ orders stuff, okay? Orders stuff from all over the country, maybe even all over the world. So that stuff starts out somewhere, is loaded on a truck, okay? Or loaded on the truck and then loaded on the train, okay? But then it comes to FSCJ. But that the material is not functional. Material is not functional till it's offloaded at the delivery bays at FSCJ. So you can think as of the conducting zone in the respiratory system as the methodology for conducting oxygen down to the level of the cells, okay? And from CO2 from the cells up to the level, from CO2 as it gets in, up to the level of the lungs, okay? But no real exchange, of oxygen or CO2 occurs in the conducting zones, just like in the arterial system. The zones are just too thick, okay? But they do have mechanisms. They do deliver, filter, warm, and moisten the incoming air. They do deliver, filter, warm, and moisten the incoming air, okay? Then we have our respiratory zones. So our respiratory zones are where the gas exchange actually occurs. So this is from the respiratory bronchioles, the last terminal portion of the respiratory system, okay? The terminal bronchioles to the alveoli. The alveoli are the air sacs. If you remember in Anatomy and Physiology 1, the slide in simple squamous epithelium that is in the textbook, okay? The slide in the textbook of simple squamous epithelium is an alveoli. And if you remember that, it's a squamous cell. It's a simple layer squamous cell, which means one layer thick, and it's one thin layer cells, okay? And that's where the exchange occurs. Anatomical features of the conducting zone. We're going to look at this diagram, and then we're going to talk a little bit about it, okay? We start over here. We have a couple of sinuses. We have a bunch of sinuses, but we have a frontal and sphenoid sinus. We have maxillary sinuses, and we have other types of sinuses. We have our nostril. We have our nasal vestibule, okay? We have these three areas that if you look inside the nose, they are protruding internally, okay? They are protruding internally towards the midline. They don't actually go all the way to the midline, and these are called concha, and they are superior, middle, and inferior concha, okay? Superior, middle, and inferior concha. And in between those concha, we have passageways, okay? We have passageways which are called meatus, okay? These meatus are openings that the air can go between the superior, middle, and inferior concha. What the concha does, number one, they have a layer of pseudostratified ciliated columnar epithelium on them, which can grasp air particles. In addition, they have they cause turbulence in air, because air is subject just like water is to turbulence. Okay, air is subject just like water is to turbulence. So if you have these outcroppings, these projections projecting from laterally to medially towards the midline, towards the septum, and air comes in, then air is going to be rotated around in the cavity. Well, it's sort of fortunate that air is going to be rotated around the cavity, because if you look up here, this is the cribriform plate of the ethmoid bone. On top of this sits the olfactory bulb. We'll see that. And through this cribriform plate, the nerve fibers of cranial nerve number 1 come through. The nerve fibers of cranial nerve number 1 come through. And this is where you have the perception of smell. The perception of smell is actually in the superior portion of the nasal cavity. It's actually in the superior portion of the nasal cavity. So that's why you see sometimes people, fanning an aroma into their nose, or actually you'll see the wine experts, or maybe the food chefs, the cooks, they will go in there and actually, if this is a wine expert, they'll stick the glass of wine, stick their nose down in there and sniff it. Okay, what they're trying to do is to get that smell up here and interact with these receptors. Okay, then we have the posterior nasal aperture. So we had the anterior opening, anterior nasal aperture. Now we have the posterior nasal aperture. We have a number of tonsils. We have pharyngeal tonsils. We have the opening of the pharyngotympanic tube. We have the opening of pharyngotympanic tube. If you will remember, there's a connection in the middle ear to the nasopharynx. There's a connection in the middle ear into the nasopharynx. This is why if you're riding in the mountains, okay, if you're riding in the mountains and you need to pop your ears, you can swallow. When you swallow, you equalize the pressure in the middle ear and on the outside. And that's because of this opening here, okay? This opening also can become obstructed, okay? In a child, it may become obstructed usually due to infection. And in an adult, if it becomes obstructed, it may be due to a tumor. So it requires a more extensive workup in an adult if you have an obstruction at this level, okay? So we have the nasopharynx, the pharyngeal tube, we have the uvula, okay? Everybody knows about their uvula, you can look in the back of your throat. We have the palatine tonsils. We have the isthmus of the fauces. This is all hard palate here, and this is all soft palate. We're just reviewing the anatomy, okay? Then we have a nasopharynx, an oropharynx, and a laryngopharynx. We're going to look at that in a little bit, okay? Then we have an esophagus. Our esophagus is posterior, and our trachea is anterior, okay? Our esophagus is posterior, and our trachea is anterior. So if you think about it, our air intake starts superior, and our intake of liquids and foods starts inferior. So if we just follow a direct line back this way, we would think that air would go down this direction, but it doesn't. It's shunted, okay? And the mechanism that shunts that is the epiglottis right here, is the epiglottis. When we swallow liquids or when we eat, the epiglottis goes over the top here. The epiglottis, this goes upward, the laryngopharynx goes upwards, and the epiglottis comes down, and it covers this opening here. It covers the opening, which if you look down in here and see the epiglottis, okay, some people have a very big epiglottis. If you're trying to do an intubation, you actually have to get the blade of the laryngoscope underneath the epiglottis. But if you're able to identify the epiglottis, then just below that, you can see the vocal cords. And if you can identify the vocal cords, then you can do an intubation, okay? So we have two mechanisms here that are providing us a way to keep fluids and foods out of the respiratory chamber. The uvula does a similar thing. As we swallow, it contracts upwards, okay, and obliterates this opening here so that we don't get liquids going down and back up into the nasopharynx. I will tell you occasionally, if you're at a funny movie and got one of those giant Cokes and they have, and if you're at a comedy, I've had Coca-Cola go out my nose because I took a breath in and started laughing at the same time, and it just went right out my nose. Okay, so it can happen, but normally we have two mechanisms. We have two structures that prevent liquids and food from going into the respiratory passage, and they are the uvula and the epiglottis. So continuing down, we're going to talk about these more in detail. We're just looking at the big picture here. This is the esophagus, which is posterior, and this is the trachea, which is anterior. We have an epiglottis. We have our vestibular folds. We have our thyroid cartilage, which is very prominent in males. We have our vocal fold. We have our cricoid cartilage, which is right below the thyroid cartilage. So if you palpate your big thyroid cartilage, there's a space in there, and then you feel your cricoid cartilage, and then below that is your thyroid gland. So we just did a brief overview of the anatomy so that as we talk about it, we have looked at the structures, okay? So we're now in the nasal cavity. We got a vestibular region, which is just superior to the nostrils. First interface with the environment, warms, moistens, and filters the air, because we would like as few particulate matter things to go into the actual respiratory passage. Sorry, I'm having to take a little bit of orange juice periodically. We have two types of membranes here, okay? Two types of membranes. Remember, we talked about this cribriform plate. We talked about the olfactory bulb sitting on top here, and we have our olfactory nerves, okay? We have olfactory nerves here that are going through the cribriform plate, and these have the sensors. These have the sensors for the sensation of smell. We here have our superior, middle, and inferior concha, okay? With our meatus, respective meatus, our hard palate and our soft palate, and our uvula. So we've covered that. So we have olfactory mucosa that house the olfactory receptors. We have respiratory mucosa, which house mucus and serous glands for protection, okay? Not only do they contain lysosomes, remember from your cell biology from chapter 3 in Anatomy and Physiology 1, lysosomes are, a lysosome is in the cell. It's a packet of very powerful digestive enzymes that will attach either to an organelle that's no longer useful, okay? Say a mitochondria is worn out, needs to be replaced, it'll attach to that double membrane mitochondria and break it down. We'll utilize everything we can. Then what we can't utilize will be expelled. Or a bacteria, it will attach to that, okay, and break the bacteria that's been brought into the cells, as we've learned about when we talked about the immune system, because we have to have that bacteria, at least, or virus portions of it, broken down so that we can put that antigen, that non-self antigen, on the surface of that particular cell, usually a macrophage, okay, or a cell of Langerhans, one of the Langerhans cells, okay, because those are antigen presenting cells, as we talked about last week. This particular type of epithelium is pseudostratified columnar epithelium, rich plexus of capillaries and veins that lie in the epithelium. Sometimes they're so rich and so thin that some people may be subject to nosebleeds. I mean, random nosebleeds for no reason, okay? Random nosebleeds for no reason, especially if you get into a dry environment, but they are people that are subject to nosebleeds, and it's because of these plexus in these areas. The heat from the blood warms the incoming air, okay? So we have capillary areas surrounding the all these things because these are cells, okay? The mucus moistens the air. We want to warm the air and moisten the air. If we warm it and moisten it, that increases the ability of the gases to be exchanged, okay? So that's the advantage, one of the advantages of breathing through your nose. If you don't breathe through your nose, then you bypass this entire circuit here. You bypass this entire circuit here. We have our three concha, our superior, middle, and inferior concha, bounded by the hard palate. We have a hard palate and a soft palate here. Hard palate is made of bone, okay? Soft palate is made of muscle and membrane, okay, or muscle and surface membrane. If you have a cleft palate, it either can be incomplete, you can have a cleft of the soft palate, or it can be complete, a cleft of the soft and the hard palate. You can have a cleft lip, which is, if you've seen it, that's a gap in the lip where the lip did not fuse, okay? Or you can have a cleft lip and cleft palate. If you are seeing those, if you go into the medical field and you have those patients, remember that Norton's, most cities do, but Norton's has a cleft lip and cleft palate clinic where you go see, you have an appointment, you have an ENT doctor there, you have a speech therapist there, you have a plastic surgeon there, you have an oral surgeon there, you get seen by 6 or 8 doctors. So the child comes in with the parents or with the guardians, seen by 6 or 8 doctors. Then the doctors meet after all, because they're seeing them differently. They're not all seeing, 6 doctors are not in the room seeing one patient at a time. Patients are circulated around, and then they will have a conference afterwards and come up with a plan and then notify the parents or guardians what the plan is and answer any questions that they may have, okay? And so they have a cleft lip and cleft palate clinic at Norton's. They usually have in all major cities a cleft lip and cleft palate clinic. So remember that those resources are available to you. And if it's something that you're interested in and you're doing your internship, you might contact them and find out if you can go over there for the clinic when the clinic meets. I think it was met once or twice a month. When I was a plastic surgery fellow in Gainesville, we had one there, obviously at the University of Florida. And then in Jacksonville, they have one at Norton's, okay? Concha, heart, are bounded by the hard palate, superior, middle, and inferior. Increase the area. Heavier dust particles are trapped in the mucus. The cilia sweep the mucus towards the pharynx. So cilia are going to do that in the trachea, and they're going to do that in the nasopharynx. They're going to sweep everything towards the oropharynx so that we swallow it, okay? So that we swallow it. We have the paranasal sinuses. We only were able to see 2, the frontal sinus here and the sphenoid sinus. We also have ethmoid sinuses and maxillary bones. And as you will aware, if you get a sinus infection, the front of your head above your eyes in the midline hurts. Both areas over your maxillary sinuses, where it's right below eyes hurt. And sometimes, it's so painful, even your eyes hurt, but it's actually, it's those areas. And so if you get a sinus infection, those are the things that are getting clogged up and not being able to drain, okay? Surround the nasal cavity and lighten the skull. So the function of, the skull is generally 2 layers of cortical bone with some spongy bone in between. We learned that in anatomy and physiology. But there are larger portions that have a high density of compact bone. And so these areas allow the skull to be a little bit lighter and weigh a little bit less. Mucus producing areas, source of the sinus headaches. And it's not because the mucus is reduced, but it is because the drainage areas get clogged up and it's not able to be discharged, okay? Then we have our posterior nasal aperture, which we looked here. and then we connect the nasal cavity with the pharynx. So this is the nasopharynx. We're going to connect it with we're going to connect the nasal cavity. This is the nasal cavity. This is our posterior nasal aperture. So anterior to this is the nasal cavity. We're going to connect that with the nasopharynx, okay? Nasal cavity is a series of highly vascularized wind tunnels, richly innervated, a liter of bacteria and microbe-killing mucus a day, okay? So about a liter of mucus is generated to try to interact with the bacteria and keep them out of your system, keep them down out of the respiratory system so they don't get dissipated. You take them down to the stomach, the first thing you do is dump them into an environment which has a high acidic pH, and that's going to take care of most of them. Homeostatic imbalance, another report, what can happen? We can get colds, viruses, we can get inflamed nasal mucosa, increased mucus production. We can get infections into the sinuses. Sinuses are very difficult to treat. And so your first line of attack is to go through these drugs, okay, trying to shrink the mucosa so that you get some openings so that you can open up the openings to allow that to drain. If it doesn't drain, just like all infections, if they don't drain, it's very difficult for them to get resolved. And so sometimes you have to go in there and manually drain those areas so that you can resolve the infection. We're now into the pharynx, commonly called the throat. We have our nasopharynx, our oropharynx, and our laryngopharynx, okay? We have our nasopharynx from our posterior nasal vestibule down to the level of our down to the level of our uvula, and then our uvula down to our level of our epiglottis, and then below the epiglottis. So these are the three different areas, and these obviously are constructs, okay, just to be able to name regions, okay, so that you can talk about the region. You can talk about the nasopharynx, the oropharynx, and the laryngopharynx, and be able to identify that. So each of us can talk about that. To serve respiratory and digestive functions, okay? Let's think about that. Air travels here. Does food travel? Hopefully we don't sniff food. So this only serves a respiratory function. We're talking about the nasopharynx. Oropharynx, we can eat, swallow liquids, and we can breathe in air. So the oropharynx serves the respiratory and digestive function. Laryngopharynx, air goes anteriorly, liquids and food go posteriorly. So we are able to take care of those two systems with the oropharynx and laryngopharynx. Oropharynx and laryngopharynx. So I might remember that. Because it could pop up on an exam. 2 out of the 3 of the divisions, nasopharynx, oropharynx, laryngopharynx, serve both respiratory and digestive functions. And knowing that these passageways actually switch, that the air inflow actually becomes anterior, and you should be able, I mean, if nothing else, you can reach down and palpate your trachea. Okay, you can't palpate your esophagus because it's behind the trachea. We have the nasopharynx, respiratory passage posterior to the nasal cavity, but superior to the entryway for food, ciliated pseudostratified epithelium. So that's our nasal pharynx, our posterior nasal vestibule down to the level of our uvula, only for respiration, okay? Only for respiration. Has nothing to do with the digestive system. Here's our old friend, ciliated pseudostratified columnar epithelium. Important bacteria-fighting adenoids, okay? Our pharyngeal tonsils, they're located up here, okay? In the old days, after your first or second throat infection, okay, you got your tonsils and adenoids out. We have subsequently learned, and I may have mentioned this previously, I think in the last lecture, or in the lymphatic system lecture, that these are very important mechanisms of fighting bacteria and preventing them from entering the body. Okay, so that's why they get inflamed. They're actually fighting bacteria. So you have to demonstrate a prolonged history of chronic infections before they consider now taking your tonsils and adenoids out. So when I was growing up in the 50s and 60s, you got none of us did, but I mean, it was very common for you to have your tonsils and adenoids out. Okay. Now it's not so common. You may be in a huge group. If we had a class of 24 and maybe only one person or no people had their tonsils out. Uvula, soft palate, force upward, sealing the nasal cavity. So if you had a short answer question, hint, hint, what are two structures in the respiratory system that seal off the nasal passage to prevent food from entering the respiratory areas? You already have the answer to the first one. And we've already talked about the second one, the epiglottis here. The epiglottis, when you swallow, drops down over the top of the voice box. We'll call it the voice box, okay? And seals this area so you don't get liquids and food, you don't aspirate food into your trachea and then into your respiratory system. You still can do it if you want to, if you swallow and try to breathe at the same time, which I've done on more than one occasion. You don't want to do that, but if you do that, I can tell you that water goes down a whole lot easier and comes back up a whole lot easier than Coca-Cola does, okay? So remember, we have mechanisms to seal off these passages, and we actually have two specific structures. One is the uvula and the other is the epiglottis, okay? Pharyngotympanic tubes open and drain the middle ear. We have our oropharynx here. Its boundaries are from the soft palate to the epiglottis. So here's our soft palate. Remember, we have our hard palate here, which is made of bone, and our soft palate here, okay, down to the uvula. This uvula so if you see somebody that has a cleft palate and a soft palate, their uvula might even be divided, okay, because you have a cleft here, okay. At this point, we transition from our pseudostratified columnar epithelium to our tougher squamous epithelium. And if I haven't talked about this before, I will mention this. Think about eating potato chips, okay? Think about eating potato chips. You chew and you chew and you chew, and you still got rougher edges, okay? Still got rough edges. Now you're going to swallow those potato chips, and they're going to scrape up against your posterior oral pharynx. And they're probably going to take a layer or two of that epithelium off because that epithelium grows all the time. Well, if you had pseudostratified columnar epithelium, that is a single layer of cells, and you would take the entire layer of cells off. This way, we've got stratified squamous epithelium. We've got stratified squamous epithelium. And so you may take a couple of layers off, but we still have other layers below that. And we have mechanisms that are constantly reproducing cells because this is an area that has a high reproduction rate to replace these cells. So if you'll keep that ideal of the potato chip in, okay, keep the ideal of potato chip. If you're trying to remember what the epithelial layer is, if it's an opening, whether it be into the oral pharynx or into the anal opening, it's probably stratified squamous epithelium. It's not keratinized. Remember, we don't need the same stuff. We don't need that keratin that we have on top of our skin, that dead material, waxy material. We don't need that in the back of the throat. In fact, that would be detrimental because it would keep the mucus from functioning, okay? So that's why we have stratified squamous epithelium. So if you etiologically or transitionally, you can think about that, then if that question ever came up, then you would have an idea, okay? Exposed to both air and food, contains bacteria fighting tonsils. So we have tonsils in these areas. Then we go down to the laryngopharynx. lined with stratified squamous epithelium. Stratified squamous epithelium in the laryngopharynx, because where are we going? We're going down into, we're not, the laryngopharynx, it starts the level epiglottis and goes down into the esophagus. And guess what? That same potato chip, there's a sharp edges is going down into your esophagus. Posterior to the epiglottis, continuous with the esophagus, food now has the right of way because the epiglottis, the movement of epiglottis, if you've got food in here, this respiratory passage is going to be closed off because you do not want to aspirate food. Food is very difficult to get backed up out of your respiratory system. And you could end up very well having to go to the hospital and get a bronchoscopy to remove that, okay? The larynx is commonly called the voice box. The larynx is commonly called the voice box. Larynx consists of the epiglottis, the vestibular fold. This is our vestibular fold right here. Our thyroid cartilage, like I say, it's prominent in males, thyroid cartilage, our vocal fold, our vocal cords, our cricoid cartilage, okay? And then as a secondary thing, the thyroid gland is below this. This is just for locational purposes, okay? For locational purposes. If you're going to do a trach, you would like to do the trach above the cricoid cartilage, okay? Above the cricoid cartilage and below the thyroid cartilage. You can actually palpate that membrane there, okay? And if push comes to shove, you can make a little nick there, a membrane, and then make a nick in the membrane. If you had a pen or pencil, you could unscrew that and push that down and push that, obviously take the refill, take the cartilage out of there. You've got a passageway now. And you would only do this, obviously, if you were in a remote area and you were hiking and somebody got a crushed larynx or something like that, because this is something you actually want to do in a controlled environment if you had to, okay? But, that is, and so when they talk about a cricoid thyroidotomy, okay, they're talking about making a hole, okay, making a hole in the trachea, in the larynx, okay, between the thyroid cartilage and the cricoid cartilage, and you can feel that space there, okay, especially if you tilt your head back, okay, which is what you do if you're doing the procedure. Sorry, went too far. Framework of 9 cartilages, okay? Some of them are paired, some of them are not. I'm not so interested in you knowing all 9 cartilages. The main cartilage, the main things I'm interested in you knowing are the thyroid cartilage, the cricoid cartilage, cricoid cartilage, and epiglottis. None of those are paired. Those are single cartilages. But what this does is, since this is such an important area, okay, so this is an important area, it's a switching area, okay? It is the area where we generate, okay, where we generate sound, and it's the area of respiratory passage. We have cartilage surrounding this network. We have cartilage surrounding this network for preservation purposes, okay? Like I say, the ones I'm most interested in you remembering is the epiglottis, the thyroid cartilage, and the cricoid cartilage, okay? These are tracheal rings here. We have these other types of cartilage here that I'm not so interested in you remembering. Just know the fact that we have a number of cartilaginous structures there to literally protect this area, protect the voice box area, while providing some rigidity to it, but not making it so rigid like the spine and the spinal system, not making it that rigid, okay? Except for the epiglottis, all are hyaline cartilage, okay? So we all, like I say, here is an anterior portion. Here's the anterior portion. Here is the hyoid bone. The hyoid bone is unique, okay? Here's the thyroid cartilage. Here is the cricoid cartilage right here. Here's the cricothyroid ligament. This is the ligament that I was talking about, okay? This is the ligament that I was talking about. And then this is a lateral view of that. But the primary ones that I'm concerned about you knowing are the epiglottis, okay, and the thyroid cartilage and the cricoid cartilage, and the fact that you have this cricothyroid membrane here in between. Three main functions: maintain open airway, switching mechanism to properly route air and food, and voice production due to vibrations of the cord producing sound waves that resonate through superior respiratory structures. So that's what's happening. And you know that if you have a infection in your nasal area, your voice is different. You know that if you have a nodule on one of your vocal cords, you get a raspy voice. One of the people that worked at Pearl Vision, who was an optician, he had a nodule and he had a terrible raspy voice. And then once the nodule was removed, his voice improved significantly. So these are the cartilages. Like I say, I've mentioned the ones that I think are most important: the thyroid, the epiglottis, and the cricoid. Don't get me wrong, they're all important. These are the ones you should know as a survey course in anatomy and physiology when we talk about the respiratory system. We have the arytenoid, the corniculate, and the cuneiform cartilages. These are paired cartilages, okay? We have the epiglottis that we've seen right here, guarding the airways. During swallowing, the pharynx is pulled up superiorly and the epiglottis tips to cover the laryngeal inlet. I'm emphasizing this a number of times just so that you know the two structures that prevent food from entering the respiratory passage are the uvula and the epiglottis. The two structures that prevent food from entering the respiratory passage are the uvula and the epiglottis. I emphasize that two reasons. Number one, it's important. And number two, it's probably going to show up on your exam, okay? And so this is an advantage if you attend a live lecture as opposed to just going through the slides. Number one, you get tips and the important steps emphasized. In case of a mistake, coughing reflex clears the throat. It's inactive when you're unconscious. That's the problem if you have a closed head injury or you're unconscious due to drugs or alcohol. You can aspirate. You don't have this coughing mechanism, so you aspirate acidic contents into your respiratory system. And more than one famous celebrity, more than one person has died this way, okay? Superior portion is lined with stratified squamous epithelium. We're talking about the larynx. Below vocal cords, pseudostratified ciliate columnar epithelium sweeps mucus towards the mouth and away from the lungs, okay? Now we're still talking about the respiratory patch. We're not going to talk about the esophagus. Remember, the esophagus stays with the stratified squamous epithelium. Oropharynx, we had pseudostratified columnar epithelium, nasopharynx. Oropharynx, we had stratified squamous epithelium. Below that in the respiratory passage, we're back now to the pseudostratified ciliate columnar epithelium, sweeping those. Now, we're not talking about kernels of popcorn. We're talking about little small things that are getting swept towards the oropharynx so that you can swallow them away from the lungs. Homeostatic imbalance, you get laryngitis, which is inflation of the vocal cords, overuse, dry air, infections, tumors. We were at a concert and was a mezzo-soprano, and whoever was supposed to be there had gotten sick and they'd flown in somebody that day, still another famous name, mezzo-soprano. And she came out and did one number and then spoke to the conductor, and they took a brief break because the air in the airplane had affected her voice, and she needed to go back there and do something and rest her voice and then come back out and do something. So people that sing are very protective of their voice, okay? And also public speakers, and a lot of them have, either home remedies or medicinal remedies or healthcare directed remedies to try to protect their voice. Trachea is the windpipe. It's the tube anterior, okay? Remember, we have dorsal and ventral. We have dorsal and ventral. Ventral is also anterior. It's anterior to the esophagus. It runs from the larynx to the mediastinum. So it's going to run from the larynx to the mediastinum. It divides into two primary bronchi at the level of the mediastinum. It's going to divide into a right mainstem bronchi and into a left mainstem bronchi. While we got the lungs up here, let's look at some general parts of the lungs. We have a right lung and a left lung. The right lung has three lobes. It has a superior lobe, a middle lobe, and an inferior lobe. The left lung only has a superior lobe and an inferior lobe. We first have our main divisions, right and left mainstem bronchi. Then we have lobe divisions, okay? Then we have lobe divisions. We'll have a division of the bronchi that'll go to the superior lobe, a division of the bronchi that'll go to the middle lobe, and a division of the bronchi that goes to the inferior lobe, okay? And then we'll have further branching that goes to the segments of the lobe, okay, the segmental portions. We have a similar thing that occurs with the vascular supply. And so if we have a small cancer up here with no other involvement, we may get by with taking a portion, one of the lobules of the superior lobe of the lung, or maybe even just the superior lobe, okay? But if it's just a small apical cancer with no evidence of metastasis, we may, terminate the bronchiole at that level and resect this portion of the lung that's supplied by the bronchiole here, okay? Or may resect it at that level and not have to do an entire lung removal for a cancer, okay? For a cancer. Same way with trauma, gunshot wound to the chest. In a normal individual, healthy, you would like to preserve as much lung function as possible while removing the damaged lung, okay? And that's one. So here, in the left lung here, we have a notch, okay? A cardiac notch. And that is for, remember the heart sits sort of slanted with the base laying on top of the diaphragm with the apex directed towards the left hip. We learned that in chapter 18. Well, this is the area where that base sits. So if you were asked to compare and contrast the difference between the right lobe, or the right lung and the left lung, you would say the right lung has 3 lobes, the left lung has 2 lobes. The left lung has a cardiac notch, okay? The right lung doesn't. Those would be a couple of things. So histology, we have three layers. We have mucosa, submucosa, and adventitia, okay, just like everything else. Notice here that the esophagus, this is the trachea here, and this is the esophagus here. The back portion of the trachea is incomplete here, Remember, the esophagus is sitting right on top of the vertebra. The vertebra is right here. So the esophagus doesn't have very much room, okay? So this is an area that may allow expansion either of the trachea, okay? Either of the trachea or of the esophagus, so that the tracheal cartilages are not they don't completely encircle the trachea. They are incomplete at this level, okay? Lined with pseudostratified ciliated epithelium with goblet cells, ringed by hyaline cartilage, tough yet flexible. We have adventitia, which is the outermost layer of connective tissue. The carina, okay? The carina is this area where the trachea branches into the right and left branch. If you get something there, that's a very sensitive area, and that will obviously interact with the cough reflex and cause you to cough. Smoking, okay? Smoking first stuns and eventually kills the cilia. Mucus and everything trapped in it can slide down into the lungs. So if nothing else, that's why you want to quit smoking. I mean, There's a number of reasons to quit smoking, okay? But one of the reasons to quit smoking is the fact that it stuns and then kills the cilia. Cilia function was to move all of that material from the nasopharynx and from the respiratory system up towards the oropharynx so we could swallow it. If we stun it and then eventually kill it, the mucus and everything else is going to slide down into the lungs. How we expel the mucus is that we forcibly expire air, okay, by contracting the tracheal muscles. We can get diaphragm irritation, okay. Diaphragm irritation may cause you to have chronic hiccups. We can get sore throat. We get mucus deposition in the lungs, okay. Smokers should avoid medications that inhibit the cough reflex. In other words, a lot of the cough, that's what a cough syrup does, okay? You know, if you are coughing a lot at night and you take cough syrup, that's essentially what you're doing. You're inhibiting the cough reflex, but you're weighing the benefit of sleep versus no sleep and coughing all night long and coughing this stuff up. So just to take it for that reason, it would be not a bad reason. In the old days, they used to give some lemon juice and some honey and a little bit of whiskey. Okay. I mean, that's literally, I saw a prescription in one of the old Facebook groups I was in. That was a physician's prescription that he had written, or he or she had written on their prescription pad to tell the parents what to mix for the child to try to keep them from coughing at night so that they could rest. Bronchial tree, last chance to warm, moisten, and filter the air, similar in structure to the trachea. One primary bronchus, we talked about that. The right main stem bronchus and the left main stem bronchus extends to each lung. The right bronchus is wider and straighter. So if you had to guess where you had an inhaled object, like if you inhaled a kernel of popcorn, okay, you were eating popcorn, you were going to swallow it and you inhaled it, okay. If you had to guess, it would probably be in the right main stem bronchus. One secondary bronchi, lobar goes to each lobe, okay? So we have a primary bronchus, and we have a secondary. Remember, we have 3 lobes on the right, 2 lobes on the left. The tertiary bronchus goes to each segment. So now we have a segmental bronchi. And then we have our bronchioles, okay? Remember, up in this, we're still talking about our conducting system. We're still talking about that truck. We're still talking about truck loading up at some point, getting on the interstate, driving down the interstate, getting off onto Beach Boulevard, going out Beach Boulevard, turning into the South Campus at FSCJ, driving around and going to the loading dock. So we start with these big branches, the interstate. So if we came out of a big city, you know, huge number of roads, okay? It gets smaller and smaller. We get off the interstates onto secondary roads, tertiary roads, and eventually we're going to get to the loading docks, okay? Well, eventually we're going to get to the respiratory bronchioles and the individual alveoli. So this is where we've been headed, okay? This is where all the action occurs, okay? Respiratory bronchioles is where the gas exchange occurs. So here's our respiratory bronchioles, here's our alveolar ducts, and here's our individual alveolar sacs, And these are the things that I talked about initially that are 1 cell layer thick with a basement membrane. We have, okay, up until this time, we've had cartilage support the respiratory system. Now the cartilage starts going away and we have elastic fibers. And these elastic fibers are going to relax and allow bronchial dilatation, or they're going to constrict, okay, and cause bronchial constriction. And so that's some of the functions of these elastic fibers. Excuse me, the elastic fibers cause the resilience of the bronchial tree to snap back. It'd be the muscles that's going to cause that. I just misspoke there. Epithelial changes. Okay, remember we started with pseudostratified ciliated columnar epithelium. We go to columnar to cuboidal, and then eventually, remember slide 1. And when we did tissues back in anatomy, when you did tissues back in anatomy and physiology 1, and you were looking at slides with simple squamous epithelium, and they were looking at the lining of the alveolar ducts. Okay, fusilia, macrophages take over. So the macrophages, remember we talked about those in the lymphatic system, but primarily in the immune system. Those were monocytes that were in the blood that came out of the blood and now become scavenger systems. So we have these scavengers. We actually have each individual alveoli have macrophages in them, and we have smooth muscle. This smooth muscle, just like in the GI system, is responsible for if it relaxes, is responsible for the dilation of the respiratory portion of the bronchial tree. If it constricts, it's responsible for shutting off airflow into these particular areas, okay? So this is the beginning of the air-blood barrier, okay? Air-blood barrier. Respiratory bronchioles branch into alveolar ducts. So we're branching into alveolar ducts. And then you can see the individual alveoli here, okay? We have alveolar sacs, and these contain clusters alveoli, okay? We sort of, just worked our way through, because now we're down, we're at the business end now, okay? We're at the business end. This is the business end of the respiratory system. This is why we have all the other stuff to get air down here, okay? At this level, we have where air is going to take exchange. We have a single layer of type 1 simple squamous epithelium. It's more thin than tissue paper, 1 cell layer thick with a basement membrane. And the alveoli are connected and they form large sacs. So we're forming so the individual alveoli connecting large sacs. And notice they are diffusely surrounded. We got the arterioles coming in, our venules going away, and this is our capillary bed. This is where the exchange occurs. This is where the exchange occurs. This is the capillary bed. This is where the exchange occurs. Just like when we talked about the exchange of nutrients and things going to the cells, that's where the exchange occurs. Densely covered by pulmonary capillaries, okay? We also have type 2 cells, which are our surfactant cells, okay? Surfactant is a very important substance. It coats the alveolar surface and decreases the water surface tension. Remember, back in the day when we talked about chapter 2, we talked about water as a polar covalent molecule. Covalent because it shares electrons, but polar because the oxygen in water pulls the electrons a little bit closer to the oxygen, a little bit further away from the hydrogen. When you do, the oxygen develops a partial negative charge, and the hydrogen develops a partial positive charge. The oxygen develops a partial negative charge and a partial positive charge. Well, these then attract one another. So the partial positive charge of the hydrogen is attracted to the partial negative charge of the oxygen. And so we have these water molecules attracted to each other. And they create that high surface tension. If you remember the slide, there was a slide where with a water bug walking across the water because of the high surface tension. Well, the same high surface tension will actually cause the alveolar sac, because remember the alveolar sac is lined with moisture, lined with water. It will actually cause it to collapse. So we secrete surfactant at a certain point in development, and that keeps the alveolar sacs open. That's why if we have a prenatal child born, okay, that hasn't gotten to the point where they're producing their own surfactant to keep see, normally you don't have to have any if you wait to full term. You don't have to have any if you wait till full term, because you're not using these these alveoli for gas exchange. Remember, we talked about that. We actually talked about two specialized structures for shunning the blood away from the lungs because we weren't using the lungs. But at full term, you would have reached a stage where you're producing surfactant. Well, if you're born before that, then you don't have any surfactant, so you're going to have the surface tension. And I'm not a neonatologist nor a pediatrician, so I don't want to tell you or don't want to speculate on how they get treated, but that is a problem for an infant that's born premature, okay? We also have macrophages that reside in and sterilize the environment. More pitfalls of smoking, we kill off the macrophages. This is a slide from Dr. Oler. The histology is fairly simple, okay? Pseudostratified columnar epithelium till you get to the oral pharynx. Then it's stratified squamous epithelium down into the esophagus, where we're not talking about the GI system. Then you go through the vocal folds and you're back to pseudostratified columnar epithelium. Then when you start getting towards the respiratory passage, the respiratory area, then you go from pseudostratified columnar epithelium to columnar epithelium to cuboidal epithelium to a simple squamous epithelium. So that's a summary thing. I'm not going to ask you to trace the epithelium from the mouth to the alveoli. You just need to know generally, if the oral pharynx is stratified squamous epithelium and the reason why. Because you have an interaction with food that might have sharp edges, okay? And you need to know why it's pseudostratified columnar epithelium. Most of the other passageways down to the level of the respiratory system, of the respiratory areas, and that's because it's the cilia are waving the particles towards the oral pharynx, and it's also providing mucus to trap particles, okay? And that's why it is simple squamous at the level of alveolus, because that's where gas exchange occurs. The lungs, we talked about the lungs. Gross anatomy, right, 3 lobes. Left has 2 lobes. Left has a cardiac notch. Multiple separate bronchial pulmonary segments that have their own blood supply and nerve supply. That's what aids us. So if you have to say you have major trauma to the superior lobe of the lung, you take out the superior lobe, but you still leave the middle and the lower lobe, okay? Separate segmental bronchi allows for compartmentalization of disease. Major portions consist of alveoli, tiny air sacs, 300 million total, okay? Remember this is the business end of the respiratory system. The business end of the respiratory system. Everything else is that interstate highway and the access roads to get that shipment to the loading dock at FSCJ. And like I told you, I try to visualize things by pictures. Okay, I try to visualize things by pictures because that way it allows me to retain it longer. Structures of the lungs. They're located, their base, inferior surface rests on the diaphragm. Okay, this is the diaphragm. Remember, in our initial talk, we talked about the diaphragm contracting. This is the diaphragm in a relaxed state. We have the rib cage here. And when we contract the diaphragm comes down to this level. That's why if you're learning to sing, they'll ask you to do diaphragmatic breathing, okay? They'll say, put your hand on your abdomen and see if you feel your abdomen rise. That's your diaphragm contracting. Now, also, if you get into a panic attack and they want you to take slow, deep breaths, you put your hand on your upper portion of the abdomen and you should feel the diaphragm contracting, okay? Apex, superior tip, just deep to the clavicle on each side. Costal surface, we have an anterior, because this sets against the ribs, lateral and posterior surface. We have the roots, okay, where the vascular, this would be the areas where you have the bronchial and the vessels go to the lungs, okay? And then the hilus is just that indentation where all that stuff goes in. We have pleura. Remember, we have 2 layers of pleura. We have a parietal pleura, just like we have a parietal pericardium. Parietal always lines the compartment. So the parietal pleura lines the inside of the rib cage, Parietal pleura lines the inside of the rib cage. Visceral pleura sits on top of and fuses with the outermost layer of whatever organ you're having. So we have a visceral pericardium, we have a visceral pleura. We have a parietal pericardium, we have a parietal pleura. So we have two layers of the lungs, okay? Visceral pleura attaches to the lungs. It actually fuses with the outermost layer of the lungs. Parietal pleura attaches to the outside wall of the thoracic cage. And there is a potential space there, okay, which is fluid filled, okay? There's enough surface tension that the lungs cling to the thoracic cavity, okay? So the lungs stay inflated. As the rib cage expands, the lungs expand. If you have inflammation of the lung pleura, okay, you can get pleural effusion, which is a layer of fluid in between the visceral and parietal pleura, okay? Obviously, if you get enough fluid, that compresses portions of the lung or can compress a significant portion of the lung. That can result in decreased ventilation from that side. So the treatment is to drain the fluid and maybe put in a long-term drain that's going to stay for a few days. You might just do a pleuracentesis, which just means taking fluid off of the lungs. You're taking it out of the pleura, okay? Or you might end up putting in a tube and keeping it for a few days to drain off the fluid, okay? Stabbing pain with each breath, we're talking about pleurisy, okay? Scarring of the pleural tissues. If you get scarring of the pleural tissues, they're not going to expand. So their ability to exchange air would be compromised, okay? You get a pleural effusion. This is an example of a pleural effusion. Increased fluid, reduces friction, but hinders breathing moments. So you can see that this fluid here is going to hinder expansion of this lung. Mechanisms of breathing. This is our last major topic. This is there's 300 something slides. And so we're going to talk about breathing. We've actually already talked about it in a way, but we're going to review what we talked about now that you know a little bit more about the anatomy. Changes in lung volume lead to a decreased pressure, okay? Increased volume, decreased pressure. If you've got a 32 pounds per square inch and a 15-inch wheel, and you take that same amount of air and you put it into a 17-inch tire, then the pressure is going to be decreased, okay? Changes in lung volume lead to decreased pressure inside the lungs, and the movement of air goes down its pressure gradient. We are at 1 atmosphere. 1 atmosphere, we are at sea level, which is 1 atmosphere. 1 atmosphere is 760 millimeters of mercury, okay? Details. Visceral pleura of the lungs is attached to the lungs. Remember, visceral means organ. Visceral pericardium is attached to the heart. Visceral pleura is attached to the lungs. Parietal pleura is attached to the inside of the thoracic cage. Natural tendency of the lungs is to assume the smallest size. Natural movement of the chest is to expand outward, increasing lung size. So this is just tendencies. Now I'm going to ask you this. Opposing forces make it easy to generate brief changes in pressure within the lung by expanding the thoracic cavity and then allowing it to recoil back. Remember, inspiration is an active motion. Expiration, not forced expiration. Forced expiration is blowing out the birthday candles, or if somebody gives you a respiratory machine and tells you to blow out as much air as you can, that's forced expiration. We're just talking about, breathing air in and breathing air out. The formal name of this tidal volume, and we'll discuss that in the second lecture on Wednesday. So if we have a mechanism of increasing the volume of the thoracic cavity, we can decrease the pressure. If we can increase the volume, we can decrease the pressure. There is a relationship there. Increased volume, decreased pressure. So how can we do that? Number one, we can drop the diaphragm there. We saw the diaphragm has this curved superiorly. When we contract the diaphragm, it descends inferiorly, allows the thoracic cavity to expand, not a huge amount, okay? Also, we can contract the external intercostal muscles. If you want to know the direction of external intercostal muscles, imagine putting your hands into your pockets, and how your fingers go into your pockets. That's the direction of the external intercostals. Well, imagine that, take that same hand and put it on your chest wall. And imagine if you contract, if you pulled against those ribs, what's that going to do? That's going to pull your thoracic cage upwards. Not a whole lot, but it's going to make a significant difference. So we've got the diaphragm dropping, increasing the volume inferiorly. At the same time, we've got the external intercostals doing the same thing. If you want to know in the abdomen what the direction of the external oblique is, you put your hands in your pockets. That's the direction of the external oblique. Little simple, little schematic things for helping you remember stuff. Okay, pneumothorax, we lose the vacuum. In the lung is collapsed. This is a normal chest x-ray. We have loss of vacuum. Either the lung has developed a leak, spontaneous pneumothorax, or you've had the chest wall penetrated with a bullet, an ice pick, anything sharp object that has penetrated through the parietal pleura and allowed the air pressure to equilibrate in there. Okay. Inspiration, expiration, changes in lung volume, changes in pressure, airflow. Okay, Boyle's law, physics law. Pressure times volume is equal to pressure 2 times volume 2, which is equal to a constant, okay, which is equal to a constant. If you change any of those numbers, okay, if you've got a volume here, a set volume here of 50, okay, and you increase this number, then obviously the pressure is going to increase, okay? The pressure is going to increase. And excuse me, if the pressure increases, the volume is going to decrease because this is a set number. This is a set number. So if this was 100, we'll just say this was 100, and the pressure was 10 and the volume was 10. We're not going to talk about units. The pressure was 10 and the volume was 10. So pressure 1, volume 1, okay? If we had a pressure of 20 here and we had the same volume with the pressure, if we had a pressure of 20, then we would have to have less volume because this is 10 times 10, that's 100. If we increase the pressure to 20, we would have, so we double the pressure, we would have to half the volume, so this would be 5, okay? So if we increase the volume, okay, so if we did the opposite, so if the volume was 10 units and the pressure was 10 units, when we apply these together, it's 100. If we increase the volume by decreasing the diaphragm and contracting the external intercostal muscles, intercostal means ribs, and we increase the volume to 20, then 20 times what number is equal to 100, okay? Because P1V1 is 100. If we've increased the volume, double the volume, then we're going to have the pressure. And so this shows a schematic of Boyle's law. What pressure is force per unit volume. So we're actually looking at these gas particles striking the surface here, So we've got a big area here. They've got to move across a big area to strike the surface here. They've got to go from this direction all the way to this direction. They'll strike it here, and then they got to go all the way back if they're doing elastic movements. Well, think about if we decrease the volume of this container by half, then these particles have less distance to travel. So they're going to strike the container. They're going to strike the container more often, and pressure is force per unit area. So we have decreased the unit area. So now these are going to strike the unit area more often. So by decreasing the volume, we have increased the pressure. And so if we increase the volume, we decrease the pressure. That's a schematic of Boyle's law. And so you need to know Boyle's law. What is the physical chemical law that governs respiration, Boyle's law. Pressure 1, volume 1 equals pressure 2, volume 2. Flow of air occurs from high to low pressure areas, so increasing the volume decreases the pressure. So when we contract the diaphragm and contract the external intercostal muscles, we increase the thoracic capacity, okay? We now have decreased the pressure. We've increased the volume, we've decreased the pressure. Normally it was 760 out and 760 in. 760 inside the thoracic cavity, 760 outside the thoracic cavity, 1 atmosphere pressure. Now we have made it something less than 760. So let's just, for an example, let's just make it 750. So we have 760 outside and 750 inside. The pressure is going to flow down this pressure gradient until equilibrium is reached. So air is going to come in from outside into the lungs. Air is going to come in outside into the lungs. Flow of air high to low pressure, so increasing the volume will decrease the pressure. If muscular contraction can increase the size of the thoracic cavity, the pressure will decrease. I've just told you 2 muscles are responsible for normal inspiration. Now we can do, if they tell you to take a maximum breath, okay, you use other muscles to take a maximum breath. We're talking about just taking a regular breath. And it's called tidal flow, okay? That's around 500 milliliters, and that will be in part 2 of the lecture. 3 pressures involved. We have atmospheric pressure, which is 760. We have interpleural pressure, which is the pressure within the alveoli, okay? That they equalize to atmospheric air, and we have interpleural pressure, which is over 4 millimeters mercury less than the atmospheric or interpleural pressure. So we have interpleural, we have atmospheric, we have interpulmonary, which is the pressure inside the alveolus, which should be equal to that of the atmospheric air. And then we have this pressure gradient, which is between the pleura, about 4 millimeters less than atmospheric than atmospheric or interpulmonary pressure. Transpulmonary pressure, the difference between the two. So we have about 4 milliliters. It's what keeps the lungs from collapsing. So this is the homeostatic balance. This negative pressure keeps the lungs from collapsing. Okay. Sequence of normal inspiration. Prime movers. That's what I meant to call. I haven't used the term prime movers, but that's the diaphragm and the external intercostals. Accessory muscles, sternocleidomastoid, pectoralis minor, erector spinae, and scalenes. You incorporate these, okay, for forced inspiration. So for people with severe lung disease, you can see them using these accessory muscles, especially the sternocleidomastoid and the scalenes. You can see their necks are tensing up. Phrenic and intercostal nerves send the signals. Phrenic nerve sends the signal to the diaphragm. Intercostal nerves obviously innervate the external intercostals. This is a schematic of what occurs, okay? The external intercostals is the external intercostals. They're going to pull the rib cage upwards. They're pulling against this and pulling the rib cage upwards, okay? Muscles relax and passive recall. So we talked about inspiration. Inspiration is normal inspiration is primarily due to the contraction of the diaphragm and the contraction of the external intercostals. The external intercostals pull the chest cavity upwards and outwards, and the diaphragm contracts inferiorly, increasing the volume of the interthoracic space. Increase the volume of the interthoracic space, the pressure goes down, air flows in down a gradient. How do we just get normal air? Normal breathing outwards. We just no longer fire those nerves and no longer contract those muscles. So if the nerves aren't if the nerves aren't fired, the diaphragm relaxes, the external intercostals relax, the volume inside the thoracic cavity increases. The pressure, which was at 760, is now greater. So let's say it's 770. I'm making these numbers up, but let's say it's 770. Outside it's 760. We have 770 inside, we have 760 outside. Air is going to flow outwards. Normal inspiration is active. Normal expiration is passive. By passive, it means we just relax the muscles. And so passive recall means the thorax just goes back to its normal shape. If we have to do forced expiration, obliques, transverse abdominals, and intercostals, okay? If we have to do forced expiration, this is what works, okay? Phrenic and intercostal nerves stop sending signals, and that's forced expiration. All right, so this is half of the lecture. This is the point that we've reached. Remember when I started the lecture, I told you that I had put up week 6, but forgot to save it. So we sort of went over the schedule. For this week, it's chapter 22, the respiratory system. We have 2 lectures on Monday and Wednesday. We have the lab, which consists of an interactive physiology part, which you've done before. You watch the animations. It's going to go over a lot of this material that we just talked about. And we have a lab, which is a PhysioX, which you will manipulate settings. You'll manipulate settings in the lungs and see what results come out from those manipulating settings. We will actually, when we finish the lecture on Wednesday, look at this in more detail. The big announcement was exam 1 closes tonight at 11:55. I have 16 people in this class. 10 of you have finished it. You have till 11:55 tonight. Do not, remember it, once you press begin, you have 2 hours to take it and it automatically submits it. If you wait till 10:30 and at 11:55, it's automatically going to submit, so you're not going to get your 2 hours. If you wait till 9 o'clock and your internet goes down, your computer goes down, we have a problem with the system, we have a problem with the system at school, then there is no other recourse. There is no other recourse than to do the makeup exam. The makeup exam you're going to do at the end of the semester when you got a lot of other things going on in this class and other classes. And the makeup exam, I have the option of it being short answer and essay. So if at all possible, take the exam. Don't wait to the last minute. That's why when we have grades to be turned in and they're due on Friday, I always turn them in on Thursday because I get OCD about not getting my grades in. Okay, I always make sure I get them in by Thursday so that I don't up against that deadline and something happens. The other thing was due on Wednesday is the Pearson assignment, the chapter test from chapter 21, which is the immune system, and the lab from the immune system, which you've done it. It was 2 PhysioX labs looking at the ELISA test and the Western blot test, which are 2 pertinent tests using to detect disease and still being used today. The ELISA test and Western blot test. So that's why those particular labs were chosen. The new assignments are the chapter test on chapter 22, which is not going to be due till a week from Wednesday. Okay. So it won't be due till 27, 28, 29th. Okay. And the lab, which we talked about, we're going to have an interactive physiology and a PhysioX, and we'll talk a little bit more about them, look at them in more detail on Wednesday after we finished up the lecture, because now we're going to, if you think about this, a lot of this first part was anatomy. Okay, we spent essentially the entire time, an hour and a half, talking about anatomy, or an hour and 15 minutes. Next time, we're going to talk about physiology. Okay, next time we're going to talk about physiology. We're going to talk about how the hemoglobin is actually carried, how the oxygen is actually carried in the hemoglobin, what the reactions are that convert CO2 to bicarbonate ion. We're going to talk about the oxygen offloading curve, okay? What causes oxygen to offload from the hemoglobin into the interstitial fluid to eventually go into the cell. And we're going to talk about the different lung volumes, what tidal volume, we mentioned tidal volume, that's normal inspiration and normal expiration, okay? We talk about total lung capacity, maximum inspiration, maximum expiration, okay? And so we'll go through the physiology portion of the lab, the physiology portion of the lecture on Wednesday. and then we'll wrap it up by looking at the labs and answering any questions you have. Does anybody have any questions for me on chat? Anybody have any questions at all? Everybody asleep. I know there was quite a bit of anatomy. The take-home message on the anatomy part is the majority of the respiratory system is a conducting system, and the actual exchange of gases occurs in the very terminal end of that. And I try to use the schematic of the load of stuff coming to FSCJ. It really, if you stopped and offloaded it somewhere else, it wouldn't, it's not pertinent. You stopped it, offloaded it at Lowe's. It's probably not going to be stuff that Lowe's could use. It needs to come to FSCJ. Same way the gases need to come to the terminal portion of the respiratory system, primarily at the level of alveolus. Any questions at all? Well, thank you very much. As always, communicate with me via email. As always, use the school email. Canvas email I have problems with, okay? It doesn't come up good on my app. I can't read the message because I have problems responding to it. I now have 3 classes. I have a Monday, Wednesday morning, Monday, Wednesday afternoon, Monday, Wednesday evening. So this class in the subject line, just put Monday, Wednesday morning. Then I know immediately which class you're in. And then that way I can direct my full attention to trying to answer your question or resolving your problem. And I'll remind you of that every time we meet, okay? It just makes 2 things. Make sure you use the school email, JAPHILLI@FSCJ, and that in the subject line, put Monday, Wednesday morning, Monday, Wednesday afternoon, Monday, Wednesday evening. You don't have to put anything else. And then once you get to the message part, then put what your problem is or what your question is, and let's go forward from that. And the last thing is, don't tag on the an email, like when I grade your test, and I'll have them graded within a week. When I grade your test, I'll send out an announcement saying your tests are graded and the exam, the scores are posted. Don't tag a question, not about, even about the test on that. Make a separate email so that we may have to go back and forth 4 to 5 times. And that's what, and in the faculty, it happens a lot where people tag on to respond to the general first email. And then by the time several people have responded, I can't find the original email. So don't do that. Well, if there's no questions, then thank you for staying with me this morning. I will see you on Wednesday for the 6 people who haven't finished their exam. My advice to you is find you a comfortable place. It's free from distraction, that you've got 2 hours free, and go ahead and take the exam and get it done. Thank you very much.